Dear friends and colleagues, I am Marco Diosani. I'm the director of the Cardiac Surgery Department at the Lancisi Cardiovascular Center, Polytechnic University of Marca, Ancona, Italy. I'm very glad to give you a welcome back to our second session on the mitral valve for our first international virtual meeting on minimal invasive and transcatheter cardiac surgery from theory to practice. Well, I think yesterday was just a great day. If I can have one slide, please. We had more than 4,500 access from more than 80 countries all over the world. So this was an extraordinary result that goes really far beyond my very best expectations. So I'm very grateful to all of you, to the participants, the faculty, the special faculty we had yesterday, CTSNet, the sponsor, and all the team that has been working behind all the time. I think yesterday was a good session. We learned a lot from the faculty about minimal invasive and transcatheter techniques for the aortic valve patients. I think key messages were that as the surgeons, as the surgical community, we have to empower our minimal invasive cardiac surgery program. This is something that our patients are strongly requesting, and also that is late, but not too late to embrace transcatheter techniques and technologies. As the surgeons, we do have all the culture, the knowledge, the capabilities, the skills to do this. So to remain key players in the management of our patients, this is something that we just have to do. But today is another day. We have to move on. We have a second session today that will be a focus on the mitral valve. We have as well a special faculty. As I said yesterday, this is not a congress. This is an all-star games. This is all members of this faculty are just giants in their fields of minimal invasive and transcatheter cardiac surgery. So I'm very honored to have them beside me, and I'm very grateful for their support and for their contribution. Let me tell just one thing to the viewers, to the participants. This is my warmest invitation to be really with us. Yesterday, the chat was just hot. We had many comments, many questions. So please do the same today. You will see we'll have different and several tools for interactivity, the chat, question, comments, but we will also ask you to vote. There will be a poll. You will have to give your opinion about different approaches that we're going to show together with the faculty. I'd like to thank CTSNet. I think that if this event, at least yesterday, and I'd like to put some pressure on the speakers of today, it was a success, 4,500 access. I think this is very much due also to the best partner one could have, and that is CTSNet, a global platform. So probably I will be, it will be good for me to say I was the first to give a congress together with CTSNet. And something that I forgot yesterday to tell is that all the content of this congress, 2 days, will be archived for late views. So all the meeting will be visible for you on CTSNet, I believe, in a couple of days, in a few hours. Last, I'd like to thank the sponsors. As I said yesterday, at the end of February, when the COVID was coming as a storm, and we didn't know what we were going through, they immediately looked at this initiative with great interest. They just said, yes, we want to do this together. We have to support this initiative. Let's do it. So I'm very grateful for that. And I'd like to recall that you can visit our virtual exhibition on this website, on the website of our Congress, to see and know more about the products, technologies that are so important for us to get good results with our patients. So I don't want to steal any more time to the scientific content of the program of the Congress. We had a bad surprise just 5 minutes ago, and that put under pressure all the technical staff. So Francesco Maisano is not going to be with us. He has been called for an emergency case. So he said probably he will join us later. I really hope so, because he has a very nice presentation to do. So we don't have time to arrange 2 moderators. So I'm afraid that Michael Borger, please let me see Michael Borger together with me if possible. He will be the moderator for this for this session. So please, Michael, would you like to give the kickoff?
Sure. Thanks very much, Marco, and thank you for the invitation to speak today. The first European that I know of derived virtual cardiac surgery meeting, and I would like to congratulate you and your team in Ancona, as well as CTSN, for a very successful first day. I am quite sure that the second day will be just as successful with the world-class faculty that you referred to. And I'm happy to function as the moderator by myself. Before I get started with my first presentation, Marco, I believe you wanted me to pose a question to the viewers with a poll. And so if we can just show the question now, please, and it's on your preferred approach to the mitral valve. So please, if you can vote for your favorite approach among either direct vision transaxillary or video-assisted total thoracoscopic. Unfortunately, I already missed the third and the fourth option there before we skipped the screen. The third option is robotic, and the fourth option is transapical coral repair, of course, which we will be having a talk on today. So if we can go to the voting mechanism, and please ask for all of the viewers that are out there to scroll down to vote for your favorite approach. We will show the results of this poll a little bit later, and then we will perform a second poll after several talks on different approaches to the mitral valve in order to see if there is any change in opinion for those of you that are watching this broadcast. So I'm hoping that the votes are coming in, and whenever the meeting organizer there feels that there's been sufficient votes cast, then I would ask just to please start with my first slide for my presentation. So my presentation is on minimal invasive thoracoscopic based surgery and why I believe that it's the gold standard for mitral valve procedures. I am the director of cardiac surgery at Leipzig, and have the great honor of following Professor Moore. Professor Moore was not the first person to realize that this approach, which we've been using for over 60 years now in cardiac surgery, is probably not necessary and maybe even not the best approach for isolated valve surgery. And Fred Moore was very innovative and started some of the first large-scale minimal invasive valve programs in the world, and certainly was also a very early innovator in robotics as well. And so these are the type of images that are often shown when people like to compare it to their own minimal invasive approaches. There are, of course, multiple different approaches which you will hear about today. This is our standard approach in Leipzig. We try to make an inframammary incision for women. For men, we make the incision about a centimeter below the nipple and then extending laterally from there. We usually enter the fourth intercostal space, but to be honest, I'm not too obsessive compulsive on counting the spaces. I look closely at the chest x-ray to try to get a feel for where I think I'm going to have the best approach to the mitral valve. But certainly one tip that I can also say is if you're unsure, just make a very small opening in the intercostal space, stick your finger in, and if you can feel the diaphragm there with your fingertip, you're probably one space too low. You should probably go up one space higher. We do retrograde cardiopulmonary bypass through the groin, open procedures usually, but we've recently also started a transcatheter cannulation as well, which works very well. So what are the goals of minimally invasive mitral valve surgery? Well, we want to achieve outcomes that are similarly excellent to those that we can achieve through a sternotomy. That is, with a high repair rate for myxomatous degeneration, with good patient safety profile. We do achieve very good visualization of the mitral valve in the vast majority of patients, and it's a very good teaching tool as well because everybody in the operating room can see exactly what you're doing, which is very different than through the sternotomy. Of course, we want to avoid a sternotomy, and we want to minimize trauma and minimize access. And it's also one of the secondary goals is that you can also use it for marketing purposes as well. You can definitely get increased patient referrals based on these minimal invasive approaches. What are the advantages over conventional mitral valve surgery? Decreased surgical trauma, decreased postoperative pain, but I always put an asterisk there because the first couple of days are quite painful, but thereafter the patients tend to recover more quickly than those that have a sternotomy. Of course, the cosmesis inarguably is better. And the quicker recovery, I would also put a bit of an asterisk there. It's not like the patients are back to work 3 days after the surgery, but I am fully convinced that it is faster than with a full sternotomy. And as I alluded to before, you can use these results to help your program acquire patients. This is one of the landmark papers published already 10 years ago by the Cleveland Clinic in the Journal of Thoracic and Cardiovascular Surgery. They had 2,000 patients, 1,000 through a conventional sternotomy, and they compared these two groups of patients, and they found that with the minimal invasive approach, there was advantages regarding cosmesis, blood product use, respiratory function, and pain without any obvious disadvantages. So once you've mastered these techniques, you can certainly leverage them to achieving excellent patient outcomes. At our center, we had an explosive growth of these operations in the 2000s. Since then, it's been more plateaued and even decreased a little bit over the last couple of years. And that's mostly because Professor Moore has trained so many former surgeons at our center in Leipzig that have gone on to become chiefs of cardiac surgery in other centers in Germany. And I think that has resulted in this slide, which I'm showing you here, and this is the legacy of Professor Moore, is that more than half of all mitral valve operations currently performed in Germany are done with a minimal invasive approach. The disadvantages, though, there are some to this approach. You have to use new instruments if you're not used to it. It's a new approach. There are some technical challenges operating with these long chopsticks. And there's definitely increased ischemic and cardiopulmonary bypass times. Although for the most part, this is not a big issue because these tend to be otherwise pretty healthy patients with myxomatous mitral valve degeneration. And there is also a learning curve, which I'll show you some data on in just a moment. At our center, we use this approach also for concomitant tricuspid valve repair, cryoablation for atrial fibrillation, and closure of PFOs and ASDs. We do think that there are some contraindications to this approach, in particular a previous right thoracotomy, especially if that's been done in the last year or two. Heavily calcified mitral valve annulus is also something I don't like to do because it is difficult to get out that calcium through those long instruments, unless we're going to do an open placement of a TAVI valve in the mitral position. Then it's a perfect approach for that. And if the patients have obvious descending aortic pathology, we don't think that they should undergo this procedure, although with isolated mitral valve prolapse, that's a very exceptional circumstance. Relative contraindications, I say complex mitral valve repair, but that doesn't apply at our center. We basically we do all repairs through this approach. And obese females with large breasts is something that you don't want to do in the beginning of your learning curve, but certainly can also be done with time. Tips and tricks, I would say that you use those long instruments through a sternotomy in order to get used to them. You want to choose the right first patient, somebody with a normal BMI and a simple mitral valve pathology. Basically, you always go one intercostal space higher than where you made your incision for men and 2 spaces higher for women. It's difficult to be too high in the intercostal space. And you want to make sure you optimize venous drainage before cross-clamping the aorta. Make sure that you see that the tip of the cannula goes all the way into the superior vena cava before you clamp the aorta. That has to be properly positioned. Otherwise, you'll be fighting with blood the entire procedure. And then you want to optimize your mitral valve exposure before starting the repair. Just to show some things that we've done in order to simplify this procedure, the loop repair, which I won't talk about in detail, but I think a lot of people know that. And we've also incorporated Ottavio Alfieri's technique for complex Barlow's valve in exceptional cases. And you can actually even do a isolated mitral valve annuloplasty for complex Barlow's as long as the insufficiency is central. Here's our setup. This is from Folkbar Falks group in Berlin, but we have the exact same setup in our center. And as I said, this gives a good exposure of the mitral valve and something that the entire team can see. As you can see on this video here, if that runs, you can get very, very nice pictures where you can closely look at the pathology, and the entire team knows exactly what your plan is going to be. And in this case, you see a very complex Barlow's mitral valve. So I'll just show some of our results quickly before wrapping up. The loop technique, I think most people have heard of this, but we found that we've been able to apply it for posterior leaflet, anterior leaflet, and bileaflet prolapse with repair rates more than 90% for all of those pathologies. And when you compare our long-term outcomes to the classic series from Carpentier, you see that at least at 8 years that we have very good results. Here's the red line at 8 years from Carpentier series, and you see that there was worse outcomes in the anterior leaflet or bileaflet group, but in our cohort, we did not see any differentiation between the 3 different pathologies. So that's why we think it's a very good technique for all sorts of mitral valve pathologies. But there is a learning curve associated with it. This was a paper from Circulation that we published with 3,895 patients from 17 surgeons, and we excluded surgeons with less than 50 cases, so we just focused on 9 surgeons. One of them, that's obviously Professor Moore as A, who performed over 1,000 of these operations. And we looked at the outcomes compared to how many cases they have done in the past. And what we saw, not surprisingly, is that there was less complications, and this is a combined outcome with all possible complications, including transfusions. And you see that the more operations that the surgeon has done, the less complications that he or she had. And when we looked at that with a Q-sum analysis, whereby you want to see the curve going down, down means you're getting less complications than expected. We see that the average surgeon really needs about 100 of these operations in order to become an expert and before his curve continuously goes down. We did have one expert, quick learner, that the curve went down from the beginning, and unfortunately he left our center and went and became a chief at another center. And then we also had one problem surgeon where he had several complications until he was basically stopped from Professor Moore. So there are different learning curves according to different surgeons. So in summary, we believe that the mini thoracotomy, thoracoscopic-based approach is feasible for almost all patients with degenerative mitral valve regurgitation. There have been some improvements in surgical instruments and techniques that have simplified the minimal invasive approach, but even then there is a definite learning curve associated with this operation, and we believe that it is the preferred approach for mitral valve surgery, but we still think there's room for new technological improvements in order to shorten the learning curve. Thank you very much. So, as the host, then I would like to introduce the next speaker, who doesn't really need an introduction. We all know Professor Ottavio Alfieri from San Raffaele in Milan, who is an icon in mitral valve surgery, and who will be talking about transcatheter present and future perspectives to the mitral valve. Ottavio?
Okay, thank you very much, Mike. It is a great pleasure to be here with you. I congratulate Marco for this fantastic initiative and for the great audience that he was able to have in this meeting. Well, the evolving approach to mitral valve interventions is going to go in the direction indicated in this slide, from open heart surgery performed either through sternotomy or minimally invasive or with a robotic technology, to closed heart transcatheter procedures. Closed heart transcatheter procedures are particularly used nowadays in patients affected by functional mitral regurgitation. Patients with degenerative mitral regurgitation, on the other hand, are preferably treated with conventional surgery unless there is a very high risk situation. As a matter of fact, with increasing age, frailty, and comorbidities and left ventricular dysfunction, the surgical risk is expected to rise. In this slide, you see the surgical risk represented with the red line, up to the point that the clinical benefit of surgery doesn't exist anymore. At that point, certainly the percutaneous interventions can have a very important role. There's a large number of transcatheter mitral valve repair devices developed over 20 years, but only about 10 devices have been used consistently over 15 years in humans. I'm going to talk about devices addressing leaflet repair, mitral annuloplasty, either indirect annuloplasty and direct annuloplasty, and also I'm going to address devices for chordal replacement. Because of the time limitation, I'm going to talk about only about some of these devices. Let's start with leaflet repair systems. First of all, I would like to talk with the mitral clip, reproducing the edge-to-edge surgical repair of the mitral valve. The mitral clip was introduced clinically in 2003, and certainly nowadays is by far the most commonly used technique to repair the mitral valve percutaneously. More than 100,000 patients have been treated worldwide. There are new generations of the mitral clip, the NTR and the XTR. These new devices have been designed with intent to facilitate the procedure and also to expand the surgical indication to more complex anatomies. A lot of scientific knowledge has been accumulated with the mitral clip. Just following the chronological order, I like to start with the Everest study. The Everest 2 randomized study related to patients with degenerative mitral regurgitation and low risk. In this particular set of patients, the results at 5 years show no difference in mortality between patients treated with the mitral clip and those treated surgically. However, patients receiving the mitral clip had a higher occurrence of mitral regurgitation and therefore higher number of reinterventions. Another important source of knowledge are the registries that you see listed here in this slide. What are the registries telling us? The registries are telling us that the great majority of patients receiving the mitral clip had a functional mitral regurgitation and were in New York Heart Association class 3 or 4. The registries are telling us that the procedure is relatively safe. The peri-procedural mortality is very low, but the residual recurrence mitral regurgitation was not negligible over time, and middle and long-term results show not a negligible mortality. This is particularly due to the clinical situation of the patient initially. An important source of information, particularly in the group of patients with heart failure and functional mitral regurgitation, is offered by the 2 randomized study which has been presented in 2018, the Mitral France and the COAPT study. These studies are showing different results, as everybody knows, and this difference was generating a great and long, extensive debate within the cardiological community. I don't want to go into the details of this. I want only to tell you that nowadays, for patients with functional mitral regurgitation in the context of heart failure, the mitral clip is offered when the co-opt criteria are met. Specifically, you see in this slide listed must be a severe mitral regurgitation by integrative multiparametric approach. Left ventricular ejection fraction should be between 20% and 50%. The left ventricle shouldn't be too large. Absence of severe pulmonary hypertension is required, as well as absence of right ventricular dysfunction. Okay, it doesn't. The edge-to-edge, the surgical edge-to-edge repair has been replicated also by the Pascal system. The system has been designed with the idea of maximizing the leaflet coaptation, reduce tension, and allow independent leaflet capture. And the study, the CLASP study, has been published and shown a low mortality as well as a high rate of success in reducing mitral regurgitation, and also a very rather high important reduction of symptoms. So this is very encouraging for this new device. Now I'm going to talk about indirect annuloplasty, and specifically I would talk about the carry-on system, taking advantage of the anatomic proximity between the coronary sinus and the posterior mitral annulus. This device has been evaluated in the Titan trial, showing a reduction in regurgitation, in the regurgitation in the regurgitant volume, reduction in the vena contracta, reduction in the mitral regurgitant orifice area, and also in the jet area. Also, very important results have been obtained in regard to symptoms. However, we have to say that a number of patients couldn't be permanently implanted with this device because of difficulty in cannulating coronary sinus, because of ineffective reduction in mitral regurgitation, and because of compression of the circumflex artery. Now, I'm going to talk about direct annuloplasty device, and specifically about the CardioBand device. The CardioBand system has been used for the first time here at the San Raffaele University Hospital in 2013 by Francesco Maisano, first in men, and since then many other patients have been treated with this method around the world. And now we have a number of publications. One is quite important, showing the one-year outcomes of this procedure and showing sustained results in reduction of mitral regurgitation. There is an ongoing trial with the CardioBand system, specifically the active trial, which aims at addressing superiority of the CardioBand device plus guideline-directed medical therapy versus guideline-directed medical therapy alone. So something reproducing the co-opt study for the mitral clip. Now I'm going to talk about chordal replacement device quite briefly. We have two devices for that. One is the NeoCord system, which has been initially evaluated in the TACT trial with 30 patients, but certainly more extensively evaluated later on by the Padua group, which repeatedly published results with this technology. In Padua, different anatomies have been treated within a NeoCord repair system, and starting from the isolated P2 lesion to more complex situations, and it was seen very clearly that satisfactory results were obtained only in patients presenting with isolated P2. So I think is at the moment a possible type of repair can be offered to patients with a P2 without too much annular enlargement. Another alternative for chordal replacement is the Harpoon device. Now the results of the Harpoon device have been published short term. The Tracer trial is going to be published soon, and this is presenting the 1-year result after implantation of the cord with the Harpoon system. The landscape of transcatheter mitral valve replacement appears to be very crowded and is expected to increase further in the future. We have experience here at the San Raffaele with the Tiara valve and with the Tendyne valve. 15 cases have been treated in this way. Certainly, we have been impressed at the high rejection rate for this type of repair. About 70% of the patients have been rejected for one reason or another, mostly for clinical reason, but also for anatomical reason when left ventricular fourth tract obstruction can be expected after implantation of transcatheter mitral valve. What you say at this point, we can only say that in the future, we can certainly expect an increase in mitral valve repair and replacement tools. So the toolbox is going to be larger and include many more devices. And the heart team is going to have the difficult task of deciding what is really the best treatment for the individual patient. We have to think that all the tools that we have, the transcatheter techniques that we have, are going to play a complementary role. So we have replacement annuloplasty, we have devices addressing the leaflets, and the great challenge for the future is to choose the right tool for the right patient to give, therefore, the best treatment to the individual patient, respecting the principle of patient-centered care. Thank you very much for your attention.
Excellent. Thank you very much, Ottavio. As always, we appreciate your insights into an area which you have really made amazing contributions to over the years and helped us understand so much more about mitral valve surgery through your many efforts. So before we start with the rapid fire presentations, maybe we can just show the results of that poll that we did at the beginning. So when we asked you to vote for your favorite approach, you can see that half of participants said robotic surgery. I'm surprised it's that high. That's amazing. 20% transapical, 20% direct vision transaxillary, and 10% video-assisted fully endoscopic. So we're going to repeat that poll after the rapid fire presentations and see if there's been any movement in those results. And our first rapid fire presentation is our meeting program director and organizer, Marco Diozanio, chief in Ancona, who will be talking about why I do direct vision transaxillary approach.
That the poll, can you hear me?
Yes, we can, yeah.
Yeah, so I can say to the audience that the poll for the next poll is already on. So if you scroll down, you can vote your favorite approach. So you won't vote at the end of the rapid fire, but you can start right now. And then we'll show the results during the discussion. So if I can have my first slide. Yes. So my first slide about transaxillary mitral valve repair is actually showing two endovascular procedure, TEVAR and EVAR. And I'm taking this example, these two procedures as an example of how endovascular catheter-based procedure have won the fight against open repair. No doubts, there is a reason, or there are two reasons. One is that TEVAR and EVAR are less invasive, so are much appreciated by the patient. But an equally important reason is that TEVAR and EVAR are simple operation, are operation that the operators love. These are operator-friendly operation. You can ask all vascular surgeons what's easier to be done, TEVAR or open replacement of the descending thoracic aorta. They will all respond the same. My second slide is showing actually our TAVI program in cardiac surgery in Ancona. As I said yesterday, we started about 1 year ago, more than 1 year ago. We've done so far 140 TAVI procedure, 95% are transfemoral now. And I think that one major lesson from this TAVI experience was that of understanding why TAVR is a game changer. TAVI is a game changer because TAVI is a game changer because my general director is calling me now live. So TAVI is a game changer because of two reasons. One is that because it's the least invasive operation for patients with AS. And the second reason is that because this is a relatively simpler operation. It is fast, it is quick, it can be learned relatively in a quick way. Even a surgeon can learn that. So I think that we should learn by these two examples, TEVAR and EVAR. If minimally invasive has to be standard of care, and strongly believe this should be the case, I think we should put energies and make efforts to develop techniques that are simple, easy, with short learning curve, while maintaining a perfect valve exposition. So this was our earlier approach, very regular, minute economy, anterolateral, you see the endoscope, you see the chitwood clamp, you see some transthoracic pericardial stay suture. We thought it was important to simplify. And when I say simple procedure, I think it's a better procedure. I don't think it's a weakness to be simple. I think it's a point of strength for a procedure. So we switched to this incision, transaxillary, 4-5 centimeter vertical incision on the anterior axillary line. And this is the cosmetic results. I think there is nothing to compare with others. I think
Yes,
from the front line, you can't see any incision. You have to ask the patient to pull up the right arm to see the scar. And it's also a very valuable approach in patients like this, which can be quite a nightmare if you want to do it endoscopically, unless you don't do an anterior thoracotomy, which would be cosmetically not so efficient. And this is a picture that tells a lot to me. It tells that this is a one incision surgery. There is no need for transthoracic stay sutures on the pericardium. There is no need for transthoracic camera. There is no need for transthoracic clamp. We're doing everything through this incision, and less incisions may mean less bleeding and less pain. And the advantages for the surgeon is that you get a perfect mitral valve exposition. In fact, laterally, the intercostal space is wider compared to a more anterior incision, and you can get the valve extremely close to the operator with a perfect 90-degree alignment. And I'd like to explain why. So if the reason is that the mitral valve at this position in the chest, very often it is oblique. So if you enter the chest to a standard minute-economy, you end up with an oblique direction toward the valve. So you have P1 quite distant and P3, which is closer and very often covered by the left atrium wall, which you can put apart with the special retractor with the Perrier stitch, and you also have the feeling of having the diaphragm on your right shoulder. Okay, this is not a problem because you can pull it down as well. And then you need a scope, an endoscope that is usually coming from this side to give a direct light to the valve and to put the valve in the middle of the screen, because that will be perpendicularly to the valve. So what we're doing is to make the incision where the vast majority of surgeons, they do the incision in order to have a very perpendicular alignment with the valve. So someone could say, but the more lateral you get, the more distant you get from the valve. So this is not really true, because using 7 or 8 pericardial stay tissue that are tied strongly to the wound and not elsewhere, not elsewhere, to the wound, because you want to bring all the anatomy towards yourself. You want to work direct vision. So you want the valve coming towards you. So 3 anteriorly, 4 stitches posteriorly, and you get extremely close to the valve with a perpendicular view. So the valve is close and you are perpendicular. And this is how the valve is exposed. You see that you see P1, P2, P3 at the same distance, very perpendicular, very close to the chest wall. And this is, again, you take the measure with the knife. This is 5 centimeters from the chest wall. You open the left atrium, and these are images that are taken not by an endoscope, by the cameraman behind me. And again, the valve is very perpendicular. This was a P3 prolapse. We're making a water test to confirm the position of the prolapse, and we decided to repair it with the Leipzig loop technique here, and you get perfect access to the subvalvular apparatus of the mitral valve. And here we're putting the loops for the following repair. And this is something that I'm not doing, tying with my fingers. This is not elegant, I never do, but sometimes you can do it. This is just to show that the valves get very close to the chest wall. And this is another case. This is a P2 prolapse flail with a cleft, and we repaired that using a butterfly resection. I don't want to talk about mitral valve repair techniques. This is just how the valve is exposed through this approach. And this is another case that we did 6 or 7 months ago. This is an old lady, very sick. We did a valve in MEC using a Sapien XT in this case. So this is our series. We started about 1.5 years ago. We've done 115 cases so far. We use all kinds of repair of techniques for valve repair. We have quite short CPB and cross-claim time because working with the good exposition without in a direct way is very easy to the operator. And these are our results showing no mortality, no stroke, no major complications, safe and efficient. So why I do a transaxillary mitral valve repair? Because it's 1 incision surgery, less bleeding, less pain, because you get a perfect valve exposition with direct vision. I'm convinced that my 3D view with my loops and my eyes is perfect. If I have to change my view, I don't have to move the endoscope. And my eyes are perfectly aligned with my hands. I don't have anything in between. And when surgery is easy, it is easy to learn. So this is one step learning curve. You just have to start if you know how to repair the mitral valve, of course. I think it is associated with the superior cosmetic results, and it's cheap. There is nothing that you need to do this kind of surgery. So please, my slide is a call for votation. Please vote. Vote Transaxillary, no doubts.
Okay, thanks very much, Marco. Very impressive presentation. We're going to have lots of questions for you later when we come to the discussion portion of the program. And I'm sure people will be submitting questions that we can be then passing on to the different speakers, which I'll be doing as the moderator. So our next speaker is Marco Solinas, chairman in MASA, who will be talking about why he does video-assisted full endoscopic surgery.
Thank you, Michael. And thank you, Marco, for this kind invitation. And it's a privilege for me to be on board also today. I see that my technique, let's say my technique, this technique, the full endoscopic mitral valve is at the end of the preference of the audience. So I will try to let you fall in love with this technique, something that happened to me some years ago. So which are the pro, in my opinion, for a fully endoscopic mitral valve? That the trauma is really, really minimal. We don't need to always external splitting or rib spreading. There is a minimal manipulation of cardiac structure. There is an incredible view of the mitral valve, and I think, I'm sorry, but I think that is the best that you can have in a minimal access. And probably a better view means also better chance of a good repair. And it obviously is feasible in redo cases. Which are the cons or the concerns about this technique? That is could be technically demanding, a longer cross-claim time, and some concern about the teaching of this technique. Uh, we don't have randomized trial to compare videoscopic mitral surgery to full sternotomy. There is this propensity match that it was published in the last years, in which we can see that also if there is a better trend in the outcome in terms of mortality, the significant, this is statistically significant, the time of extubation, discharge, ICU stay, and use of blood products. And I have to say that if nowadays in which the hard point like stroke or mortality are 0 point, I think that we have to focus ourselves also on this, let's say, secondary endpoint that are more and more important in the lifestyle of our patient. On the other hand, if we go through thoracotomy, direct vision, or also full endoscope, we do not harm the lung, and so the pulmonary function of our patient is preserved. From this paper that was published in 2016 by Reck and Spurner, we see that a comparison with video-assisted or direct vision, let's say, to full endoscopic mitral valve tell us that there is no difference in terms of cross-clamping or cardiopulmonary bypass time. There is a significant difference in terms of length of stay in the hospital, and probably this is due to the pain. You can see that the patients that were treated full endoscopic without rib spreading had a very, very, very less pain. Less pain means also probably a better pulmonary function and a quicker return to physical activity. Because I'm really convinced that in surgery, fail to prepare means prepare to fail. We took a CT scan to our patient, and this is our setup. We do a periareolar approach for men and transaxillary for women. And we have also developed, we have done some work on on our CT scan to see if there are variables associated with difficult exposition, and we found that pectus excavatum, diaphragm elevation, and a lateral diameter that is less of 14 centimeters could lead to a poor exposition. So, especially the beginning of experience, try to avoid those kind of patients. Well, this is a short movie about a repair. We do a percutaneous cannulation of the superior and inferior vena cava and a femoral access for the aortic perfusion. When we are on bypass, we open the pericardium. We put the push strings on the ascending aorta, clamp the aorta, we deliver cardioplegia, open the right atrium, and expose the valve. Well, the exposition of the aorta and the violar valve is amazing. You can really check everything, the leaflet, the annulus, the subvalvular apparatus, and you have a very quick access to everything. In this case, our planning for the repair was to use some neoports, and you've seen how nicely you can see the papillary muscles. Ring, the core knot for the suture of the ring. So this is the result when we are happy with the position of our cords, and then obviously we check the final results at TE. So very nice coaptation with no leaks. And this is the cosmetic results after a couple of months. But one of the concerns is that is this technique so difficult? Is possible to teach this technique? We have seen, we went in our practice and using the Kazan curve, we look at the learning curve of some of my young surgeons, and you can see that also if you take the whole procedure, or also if we analyze the surgical setup, the CV duration, the cross-clamping duration, you can see that the procedure never touched the high boundary and always remain in control, and those surgeon needs more or less 50 patients to touch the lower boundary. And we did also another, let's say, analysis between two surgeons, a senior surgeon, Surgeon A, that I am. This was my experience when I decided that after 12 years of direct vision, I was feeling, let's say, ready to go fully endoscopically. So as you can see, my experience, the procedure was always under control, but I need more or less 150 cases to touch the lower boundary. Surgeon B is a young surgeon that I trained and mentored, and my let's say the meaning of this slide is that you need, with a mentoring and a teaching program, only 50 cases to touch the excellence. So, in conclusion, why I do? Because it's feasible, it's reproducible, it's teachable and learnable, it's for sure cost effective, and is safe for the patient. Thank you.
Excellent. Thank you very much, Marco. Fantastic video there. Very nice presentation. Our next speaker is Dr. Navarre from St. Luc in Brussels, and he'll be talking about why he does robotic mitral valve surgery.
Good afternoon, everybody. Can you hear me?
Yes, perfectly. Thank you.
Okay, thank you very much. It's an honor to be here with you today. So my presentation is about my approach in mitral valve repair. I do robotic, and next, okay, that's my. So why I do? I'm sorry. The minimally invasive technique has been introduced to decrease some way the invasiveness of the full sternotomy in conventional surgery. So the objective was of minimal invasive is to reproduce a mitral valve repair as in conventional surgery, and with a minimal scale, of course. And that's, I'm sorry, next slide, please. Okay. Why I do robotic? Of course, because the quality of repair, it's similar to the conventional technique, with a lower occurrence of complication. Even if, in case of robotic surgery, usually operative time are longer, and there is a technical complexity with higher. Usually, this complexity and longer operative time are compensated by the lesser invasiveness and the shorter hospital stay for the patient. But there are, of course, some advantage for the surgeon who perform this minimal invasive approach, because in robotic surgery, we have really an optimal visualization of the mitral valve, of the leaflet, of the papillary muscle, with this 3D camera with 10 times magnification, who give us an experience that I call a full immersion with the use of this console. More, we have an optimal assessment of the valve lesion at level of both mitral of tricuspid valve. We have an extremely fine dexterity that is not possible to reproduce with the human arms. We have a greater degree of freedom with the end of wrist. And we have even this fantastic tool with this dynamic retractor that allow an excellent of the mitral valve in most of the situation. We have some other advantage that I call an ergonomic advantage for the surgeon, because a robotic assisted procedure, usually we have an ergonomy that approach that is similar to the conventional surgeon. We have an adjustable high-hand coordination that is modified in a video assisted technique. We do not have any fulcrum effect without inversion of movement. So when we use robotic arms, we reproduce the movement of our hands without any inversion of the movement that we are obliged to do in our port approach. And let's say that in general, we have a good ergonomy when we use a robotic approach. I'm sorry, next slide, please. Very important in robotic approach is the patient selection. As many published study confirmed, the rigorous patient selection is capital to avoid any predictable complication, any complication that we could just predict with a right patient selection. In Brussels, with our own algorithm and that is similar to other group algorithm as a New York or Cleveland group algorithm. So we usually address to robotic approach all patients with severe regurgitation without previous thoracic surgery, severe MAC, severe pulmonary hypertension or left ventricular dysfunction, or with peripheral arterial disease. Next slide, please. So briefly, our surgical protocol include a mini thoracotomy at the level of the 4th intercostal space that we use as a working port, camera port, and cardioplegia port. Usually, we put 3 trocar for the robotic arms and 1 5mm trocar for the left venting. Our trocar are positioned at the fourth, at second and sixth intercostal space for the robotic arms, and at fourth in the medial line for the atrial retractor. And once we positioned all the arms for the robot, we go to the groins. We perform a 2 to 3 centimeter incision to the groin, and we do direct cannulation of the femoral vessel. We use only a single venous cannula with a long neck multiperforated cannula, and that's enough for most of the procedure. Only in case I do some tricuspid repair, I use a second cannula in the superior vena cava through jugular vein. Once we are inside the chest, usually I open the pericardium before to go on pump, and usually I use 3 pericardial stitch positioned at the level of the inferior vena cava, in the middle of the 2 pulmonary vein, and one at the level of the superior vena cava. Usually I open all the pericardium this way, I put the 3 stitch and I go on pump. Once I go on pump, I put my purse string on the aortic roots, because I perform an antegrade cord crystalloid cardioplegia that I administrate direct with a long neck cardioplegia cannula. And most of the patient I do a transthoracic clamping with a classic Chitwood clamp. So that's my surgical protocol. Concerning the valve repair, and that's you can see the positioning of the cardioplegia cannula at the level of the ascending aorta, and it's a direct visualization with the help of the robotic arms, of course. Next slide, please. Okay, I use a conventional repair technique for most of procedure. So annuloplasty technique, I always use a complete ring, because in our center is the institutional policy to use a complete ring for most of the mitral valve repair. And in the beginning of our experience, we used a node pusher to fix the ring. Now more and more we use for all cases the scored node, who allow us to spare around 15 minutes. Concerning leaflet procedure, usually we use all kind of technique, but of course more and more we use neocord and triangular leaflet resection. And more I associate both technique to have really a stable result, a durable result, and some way to improve the durability of this repair. Of course, even I like to use robotic because I think it's easier to perform complex repair, as in this case at the calcification of posterior annulus. Here was a large calcification on P2, P3 that you can easily repair with a robotic approach, because really you have the facility to use this endorace, this very efficient instrument, and this very, very efficient atrial retractor. Or even in some case of large prolapse, you can perform a sliding plasty as in a conventional repair, as a conventional approach. I'm sorry, next. Okay. Oh, I'm sorry. Another thing that is very important for the success of a robotic program is to have a dedicated robotic team. And in our center, from the beginning, we are trying to use include all the team, all the people working in the robotic in the team, and that includes surgeon, of course, anesthesiologists, perfusionists, and nurse that, as you can see in my screen, that follow the procedure as the surgeon. Everybody has his own screen to follow the procedure and to feel, to be part of this program. And to finish, I think there is this second console, the double console, which is really an helpful tool for the learning, but even to train a young surgeon who start with robotic, because of really although, as you can see in this video, an interaction between a senior and young surgeon that can really be helpful during a training and in a complex case. And the simulators that give you the opportunity to work in a dry situation, to really train and to be more effective during the surgery. Next slide, please. So to conclude, I use robotics because I think it's really an excellent tool for minimally invasive approach in cardiac surgery. The result, of course, are good, but you need to have a high volume to be comparable with conventional surgery. So I will say the key of the success of a robotic program are high volume, a dedicated team, and a patient-drive algorithm, so really a good selection of patients to avoid all predictable complications. Thank you very much.
Thank you very much, Dr. Navarro, and it's my great pleasure that Francesco Mazzano has now joined us. Welcome, Francesco.
Hi, Michael. Yeah,
we have one more presentation in the rapid session, and then we're going to go with a poll to see what the preferred approach is from those people that are watching right now. So Gino Geroso will go with the last rapid presentation on why he does a transapical chordal repair, and then we will go to a discussion. Gino, you're muted.
Boycottage.
There we go. Okay. No, unfortunately we can't. Can we unmute Gino centrally? Just to remind everybody out there while we get the audio visual here worked out with Gino, we will repeat the poll on the preferred approach. There we go. Having some technical issues,
so
Francesco.
It happens. I mean, although we learned a lot about social distancing and online courses, we still have this kind of problems on a regular basis.
So
sorry, guys, I was late.
No problem. Maybe until we get Gino back online, do you think this is the future for meetings then, Francesco? Are we going to be doing all of our meetings like this?
Well, you know, I've been running a postgraduate education course, which was based on weekly presence in Zurich. So the students had to come here for 4 weeks, 5 days for each week. And as the Corona crisis came out, we decided to switch to online courses, which was perfectly okay. You know, you can do a lot of sharing online. The problem is that worked very well because it was a small group of people and we know each other. And it was also a way to stay together. You know, it was very, I would say, it was very touchy, because we could update each other what happens in our own hospital, in our own country, and even in our own families. Now, whether this should be the future of scientific communication, I hope not, because I think we should keep an opportunity to meet in person. I see anyhow a role of this kind of approaches, because obviously it's very efficient, but I hope that we will still be able to meet in person and have some physical contact, you know, so there will be no problem like with Gino now. Gino, can you speak now? Not yet.
Can you hear me?
Again. Yes, perfect.
Yeah, can you hear me? Okay.
Yes.
So you're hearing me. Okay. Thank you. So first of all, I would like to thank Marco De Usanio for kindly inviting me. And if I can have the slides. Yes, I took the liberty, the freedom to rephrase the title of the meeting. I know that is a little bit unpolite and not very humble, but I will rephrase in minimal invasive and micro-invasive cardiac surgery. And I would rephrase as well the title of the session from minimally invasive mitral valve repair, why I do it, in micro-invasive mitral valve repair, if you are talking about transapical chordal repair. Why is that? Because if you think about the Big Bang, and we compare the Big Bang to the ability to repair structural heart defects, so let's say that the first revolution was back in 1953 when Dr. Gibbon was able to repair an atrial septal defect using the cardiopulmonary bypass. So after 70 years, what is the second revolution? Well, the second revolution, if the first revolution was the cardiopulmonary bypass, the second revolution, if the slide is going, yes, the second revolution after cardiopulmonary bypass is no cardiopulmonary bypass anymore with the TAVI. So if this is the second revolution, okay, I would say that the same way that we apply for technology, moving from normal or mini or micro, we can have a second revolution, shifting a paradigm in cardiac surgery from standard cardiac surgery, that means the ability to repair structural heart defects using a full sternotomy, cardiopulmonary bypass, and cardioplegic arrest of the heart. Now we move to minimal invasive, that means the ability to repair a structural heart defects using a small access, but still using cardiopulmonary bypass and cardioplegic arrest of the heart. And then we have micro-invasive cardiac surgery. That means not only minimal access, but also the ability to repair structural heart defects from the heart without using cardiopulmonary bypass, without cardioplegic arrest. So this is we can say that the real revolution begins now with the microinvasive cardiac surgery, taking advantage of the transcatheter technologies. So if you compare minimal invasive versus microinvasive cardiac surgery, you see you do on beating heart, you don't need the cardiopulmonary bypass, and compare what we have seen so far is shorter than conventional and shorter probably than minimal invasive. Now, having said that, this is a really new journey embracing intervention that has been already pointed out by several speakers before. Now, the slides are a little bit slowly. So, if you're talking about microinvasive cardiac surgery, we have several technologies that we can apply with this concept. That means not only the ability to replace the chordae, but also the ring, or you can have also combined procedure. And so I'm going to give you some glimpse on these possibilities. For example, if you think about the neocore repair, I know that Ottavio Alfieri already pointed out the results of this, so I'm going very quick across these slides. You know, this is a beating heart off-pump microinvasive surgery that you can repair, prolapsing leaflet, placing artificial chordae through the apex of the left ventricle. And Andrea Colli, who used to work in Padua and now is a chief in Pisa, he actually investigated a lot and reviewed all the data. He was able to actually to identify two indexes that we can use, and according with those indexes, we have also magic number that we can apply, because patient selector section, as already pointed out by Navarro, for the robotic surgery is a key point. These are the overall experience worldwide. Now in Padua, we have done over 220 cases, so worldwide have been performed over 1,000 cases. And of course, having done over 200 cases, we were able, as Ottavio Fiori pointed out, to identify, to stratify patients according to mitral anatomy, so type A, type B, type C, type T. And you see the results are definitely better for the type A patients, that mean isolated P2. And this is depicted also in the experience of the European registry. Now, this is a paper that I think, Michael, you are very familiar with this, because when we started with this experience, everybody was claiming the fact that we were not implanting the ring. Now, if you select accurately your patient, you don't need probably a ring if you're repairing the prolapsing leaflet. These are 3 patients from the Leipzig series with a follow-up up to 5 years. And you see that in select patient, mitral repair using the NeoCore system results in a very good long-term without recurrent prolapse, and the ring remains stable, even if you are not implanting the ring. And these are data up to 5 years. Now, of course, there is a second generation and the new comers like the Harpoon system, and data from the Harpoon system has been already presented, and I will pass through them. And also there is the transfemoral approach for neocord implantation, like you can see in this video. So the evolving technology, of course, is extremely important. When you go back to the Harpoon system, you see there are few data, because there are the data just of the results from the CE Mark trial. We were involved in that. And Jim Gam is now presenting the data up to 1 year. So you see results are satisfactory, but not that satisfactory if I compare with my previous neocord experience, because these are isolated P2 prolapse. And you see, if you look at the result, there is a 76% percentage of patients without or with less than mild mitral regurgitation. However, you can use also to mimic the edge-to-edge mitral repair, the Alfieri stitch, using the neocord, and also you can use you can place a ring like the Valker through the apex of the left ventricle on the beating heart without using cardiopulmonary bypass. You can have also a combo procedure, that means to combine the application artificial neocord to the ring technologies like the Cardioband or the Valker. And also you can apply this technology, that means the neocord, to other transapical procedure like the TAVI. And this is a patient we operated a couple of years ago doing a aortic valve replacement using a TAVI approach, and the mitral valve repair using a neocord approach. So at the end of my presentation, and before the poll, I leave you with this sketch that you can read, but the final message for the poll vote is for all the surgeons, don't be afraid, please go micro. Thank you for the attention.
Excellent. Thank you very much, Gino. Marco, should we be doing the poll one more time, or should we just show the last results here? I'm not sure if he's still with us. There we go. So there's our before and after results. You can see a shift away from robotic, but I think that may have reflected increasing number of participants for the second poll. The first poll we held right as soon as we started, and there may not have been quite as many participants, because that really shocked me that 50% of people said their preferred approach was robotic. There are several questions that have come in from viewers, and one interesting one for Professor Alfieri is, do you think the transcatheter approaches are going to actually replace conventional mitral valve surgery in the future?
The audio is not so good, but you're asking about transcatheter mitral valve replacement?
Well, will it be used for all patients in the future, and that will completely replace conventional surgical techniques?
Oh, Yes, I think that this is going to be the direction. If you mean a conventional, you mean sternotomy as a conventional surgery, I think that this is the direction. Anyway, I would like to point out that, in my opinion, the big step is between open heart and closed heart transcatheter procedure. I see some difference, certainly, and this has been repeatedly demonstrated, some advantage of minimally invasive techniques, but at the end, is not a great advantage. And the big step will be between cardiopulmonary bypass and non-cardiopulmonary bypass. As a matter of fact, there are many centers in the world using sternotomy, still sternotomy, and these are the best centers of the world. So just to tell some example, David Adams in New York, Bowling, and other people, Tyrone David, and so on, they're using sternotomy with excellent results, and apparently cardiologists are very happy and patients are very happy as well. So I think that the big step really would be between non-cardiopulmonary bypass and cardiopulmonary bypass. This is going to be the big step that we are going to face in the future.
Okay, thanks very much. That was Bhaskar from India that asked that question. We have a question for Adrian from the USA, from Marco. What do you think that the transaxillary approach can be used even in centers with small volumes?
Yes, I certainly believe that. Yes, this is a very easy technique to learn. So it is particularly useful for the small volume patients, for the small volume centers. Not all centers have the opportunity to perform hundreds of mitral valve repair per year, so they don't have the time to develop the setup for endoscopic or robotics. So this is a one-step learning curve. You just have to start. As long as you know how to repair the valve, the technique is very, very easy. And so for sure, yes. Could you hear me?
Yes, we hear
Very
you
well.
perfectly. And Shibikom from Ethiopia has a question for Marco Solinas. What about future trainees? How are trainees going to learn conventional mitral valve surgery if all of these procedures are being done with the techniques that we are talking about today? Marco Solinas, are you there?
Yeah, I'm here. Can you hear me?
Yeah. Yes.
Can you hear me now? Okay. I understood the question. I mean, I was answering that I think that videoscopic valve surgery as robotic surgery have the great advantage that with the scope you can really teach not only the access but also how to repair a mitral valve. It's very, very important. For sure, the problem is that until we don't have in our teaching hospital a real program on minimal invasive technique, it will be very difficult to get this training for sure. So this is a problem, but I think that the tool itself is very, very helpful. And with the mentoring, as I showed in the presentation, with a good mentoring and a good teaching program, you don't need, the learning curve is quite flat.
Okay. Marco, you wanted to make a comment about that? Marco
Yeah,
D'Assanio?
I have a question. For sure, with the endoscope, you have a very good view, and with the direct access, this is, there is vision for just the operating surgery. But today, there are available some head cameras, 4K with the image stabilization that makes perfect vision, and you can record all the surgery you're doing. So you can replicate you can have a screen behind you that is visible to all the rest of the team, the nurse, the trainee, and everyone. So I think training is important. We are an academic hospital, so training is extremely important. But that is a problem that can be solved. And when I think about learning, it's not just and training. It's not just the surgeon. It's not the other assistant that has to learn. It's all the entire equipe, the nurse, the anesthesiologist, the setup in the operating theater is changing. So this is you're requesting extra work to everyone in the OR. If you're doing direct, you just schedule the patients for direct and you work direct. It's just like mini AVR through a mini sternotomy. You don't need particular setup or nothing. You just do it.
Gino, you also have a comment?
Add a comment.
We've
Being a director of a residency program, I'm not worrying for the future cardiac surgeon to be fully trained in transcatheter or minimal invasive cardiac surgery. I'm really worrying about the ability, the possibility to train those surgeons for very complex open heart procedure, like redo surgery that is declining because of the transcatheter procedure. So I'm worrying the other way around for the very complex open heart procedure, open heart operations, because these are declining quite a lot. So at that point, you need a very, very high volume hospital for training program, because you have to provide to your trainees those type of operation more than the transcatheter operation.
Yeah, I agree with you there, Gino. This is also a concern of mine, and that's one of the strong arguments for centralization of resources. That's a real hot topic in the United States. It's very difficult to close hospitals and to centralize there, but in Europe we tend to be it's a little bit politically more feasible for us, and there are many advantages to that when you do have large volume hospitals, as Emil also referred to in his presentation. I have also a question for Emil, is from Cooper in Canada, who wants to know a very practical question. If you have a post-op bleeding problem after a robotic mitral valve, do you attempt to fix that robotically, or do you go to a sternotomy?
I go through the thoracotomy using. Usually, we don't need really to go with the robot inside the chest to control a bleeding, and usually you go from the same thoracotomy. And I have to say that bleeding and robotic surgery are really rare. So usually you don't really need it.
When it does happen, though, do you use a double lumen? Do you have the anesthetist put in a double lumen endotracheal tube?
All patients, I use a double lumen. Sometimes where it's very difficult, my anesthesiologists, who are really good anesthesiologists, use a bronchus blocker with a normal tube and a balloon in the right.
Okay, I think in the interest of time, we have 3 more excellent presentations, but I just want to ask one more quick question to Gino. Somebody wants to know about post-op LV remodeling, and can that lead to MR recurrence after the neocord or harpoon procedure?
Okay, so everybody was worrying about this remodeling. You know that the reduction in size and volume of the left ventricle would at the end determine recurrence or mitral regurgitation because of the elongation of the artificial chordae. That's not really the case. Of course, you have a little trick to keep the tensioning of the chordae quite stiff at the beginning. But really, recurrence of mitral regurgitation after a neocord procedure is basically due to rupture of the leaflet or severing of the other chordae due to the artificial chordae that you have placed, either on the anterior leaflet if you treat the posterior leaflet, because of course you can encroach the chordae and over time have a severing effect. That's the major reason.
Yeah, if I can also just jump in there, the reverse remodeling that occurs after a mitral valve repair operation occurs mostly in the long axis of the left ventricle. It doesn't occur between the tip of the papillary muscle and the mitral annular plane, And that's why with the neocord, as we've evolved with the procedure, we're trying to more closely imitate that angle from the papillary muscles. Marco, you had also a comment?
I have a question for Professor Alfieri. I'm very interested on the technology that has been shown by Gino Gerosa, the transapical course. But I would like to know the opinion of Professor Alfieri about the ring that we're not placing. What's your opinion about that? With neocords,
This is
you don't use a ring to stabilize the
weak.
result. What's your opinion about that?
Certainly, this is the weak aspect of the transapical technology, not to be able to address the ring. We know very well from experimental studies which have been carried out in animals that after a few weeks of iatrogenic mitral regurgitation, the ring is enlarging. And therefore, you can expect that the ring is almost invariably enlarged when you have a substantial mitral regurgitation. So I think that this is the weak point. Maybe the result is going to be perfect immediately, but I feel that in the future the technique is not giving a sustained results. This is my opinion.
But if I can jump in on there, Ottavio, we have to remember also that mitral valve leaflets grow. Every time you do a mitral valve repair with a degenerative patient, you see how long the leaflets are. So
I don't hear anymore.
So as long as the leaflet has grown, or let's put it this way, as long as the annulus has not dilated out of proportion to the leaflet growth that occurs during mitral regurgitation, if you can still catch the patient in that time frame, you can still treat them with an isolated neocord type procedure. But I agree with you, it's a small proportion of patients. Gino, do you want to comment there?
Yes, I'm sorry to disappoint you, Ottavio, but I disagree with you because if you remember, I mentioned those magic numbers. So patient selection is crucial. You cannot treat with the neocord any patient with a dilated annulus. You need to have that indexes that can provide you with some, let's say, suggestion that your repair will be durable over time. But now we are reaching 5 years of follow-up on quite a high number of patients. And again, as I mentioned before, annular dilation
Gino,
is not being
if you don't have dilated annulus, you don't have dilated ventricle. So there's no sense to talk about remodeling. So
yeah,
I think
I'm
that
sorry to disappoint you
patient
because we are not treating patients that don't have a dilated annulus. But let's put it in another way. If you have enough tissue to counteract, let's put it in this way, that's a better way. For probably I express myself not that good. If you have enough tissue to counteract, enough leaflet tissue to counteract the dilated annulus, you're running for a winning situation. If you don't have enough tissue, leaflet tissue, to counteract the dilated annulus, you're running for failure. That's for sure.
it is
That's
a very
why
small.
patient selection.
It is a very small number of patients anyway. It's very small.
I can give you
the
our experience. Over 220 cases. We were very lucky to encounter all those patients all over the world. But I'm sorry that there are only 3 patients in Leipzig paper that I presented before. But those patients without recurrence of mitral regurgitation, because there was no rupture of the chordae, those annulus, they remain stable over time up to 5 years. Am I correct, Michael, saying that?
Yeah, if there's no MR, the annulus stays stable unless the patient has atrial fibrillation. But the annulus only enlarges once you have MR. But Alfieri, I agree with Ottavio's point in that annular dilatation occurs very early in the disease process, but it's a matter of catching the patient in time before they have unproportioned annular dilatation in relation to the length of the leaflets.
Yeah, you have to be very aggressive. Yeah, you have to be very aggressive if you want to do that technique and to do a very early repair.
I've been silent till now.
Marco,
Let me jump in 1 second because I think I would like to say one thing. First of all, annular dilatation is a bad definition. I rather prefer annual mismatch, which is exactly what we're talking about. That is, the annulus is larger than the amount of leaflet which is available for coaptation. Secondly, I think, Gino, I agree with you and I disagree with you. No, I agree. Most of what you say is correct. This procedure works well in P2 prolapse. You need to be very clear. The ideal candidate is ideal kind of procedure. You know, when you want to learn minimal invasive mitral, when you want to teach the first repair, you're gonna find this patient, P2 prolapse. This is the best. So in this ideal patient, the question remains open. What is the best treatment? I have to say. And I agree with you that if you have a patient with enough leaflet redundancy in the region of the prolapse, you may have an excellent result with this technology, but you need to be very selective in finding the right patients because you just produce this evidence. As if you go beyond this indication, you may get not so good results. So I really believe that it is, isolated chordal repair may be one way for the future. It's not one single way. So when I hear also the discussion, what is the best solution for patients, what is the best technology? At the end of the day, there are many ways to go to Rome. So always need to Rome.
Okay. Maybe we'll use that as a segue. I believe Francesco's connection is breaking up a little bit. Marco, just one more quick comment. Otherwise, we're running past time here.
Okay, thank you, Michael. Just a very quick comment. We started this session, and you started this session telling us that we don't have any way, compromise the surgical result. Well, at the moment, we are talking about a technique that have no comparable result to standard surgery. So probably it's a little bit too early to have all this discussion. At the moment, we cannot compare.
Yeah, and this reflects one of the viewers' questions is that, should we really be comparing ourselves to the cardiologist? My answer to that question is what the cardiologists achieve through pure transcatheter techniques. My answer to that question is yeah, we should be comparing ourselves to that because that's what the patients want. And it is progress, it is innovation. And eventually we hope that we can get to the point where we can do everything with the least amount of trauma. And I think that's our common goal here. How exactly we get there, we can argue about that. But and using that as a segue, I think we will go on with the next part of the session here. I don't think our speaker needs any introduction either. Francesco Maizano, the Director of Cardiac Surgery in Zurich, will be talking about evolution in transcatheter mitral techniques as a surgeon. Francesco.
Yeah, so there is no better introduction than the discussion we had until now. So I will rapidly go into the presentation. These are my disclosures of conflict of interest. Very important to disclose all of them, otherwise you get into trouble. I will tell you the story in the future. Well, it's a long story. And when we discuss what the cardiologist achieved with cardiac procedures, don't forget that the main procedure, which is done all over the world, is originated by Alfieri, which is a surgical procedure. So what the cardiologists are achieving is just what we introduced or what we were part of it. And I remember that in 2005, Ugo invited me to give a lecture at a techno college, which was highly disregarded by the community. Everybody was saying this was not going to be the future. In this lecture, I was talking about TAVI, which is going to be the next way to treat every patient with aortic stenosis, and as well for mitral. So things are happening, and you can't stop evolution. And I don't think is a big challenge to understand that evolution has been always a challenge for everybody. It takes many years to develop a routine. If you develop your standard sternotomy, it's very difficult to go into minimal invasive. That's why David Adams and other surgeons are not entertaining the risk of going minimal invasive. The same applies for those who love robotic today. They may not be happy to dismantle 10 years of practice to achieve a standard and go to the next step. But the reality is that the solutions are going forward. And again, if you read that these are slides from 2005, and these are actually still actual today. I have obviously a different perspective than many others. In my personal career, I went through the steps that we all probably experience in different ways. I think most of us have been learning cardiac surgery. The first operation was ASD closure. Today, to be able to do an ASD closure surgically is almost impossible. You know, we close all these holes with devices. The same applies for commissurotomy. You know, open commissurotomy is not anymore a surgical procedure. We only do this in patients who have a contraindication for surgery in most occasions. So, for balloon valvuloplasty. So the evolution of structural interventions is in the direction of less invasive. What is the limit? Obviously, there are some anatomical limitations. I don't think every patient should be treated endovascularly, but for sure, there is a majority of patients who will be in the future treated endovascularly. A few of these patients will be treated open surgery. Now, the thing is not happening in one day. These procedures are not cardiological procedures. If you want to make a clear distinction between cardiology and cardiac surgery, which is also, in my opinion, a very old way of thinking. But these procedures, the whole field of mitral interventions was originated by Alfieri, by his crazy idea of joining leaflets in the middle. And Alfieri has been highly criticized for many years. In 91 had the idea, the vision, came in 98 after scrutinizing the data and seeing that actually was a good therapy. The idea of a catheter-based version of this surgical procedure came along, and it took 20 years. 20 years. We're not talking one day, 20 years to bring this into reality. Bring to reality what that means. Bring to reality is that this is a procedure which is performed in many institutions in the world, is a true alternative to surgery, and actually achieved one goal, which has been a holy grail for a lot of surgeons, that is the one to show that treating functional MR may be beneficial for some patients. This is the video of the announcement of the co-op trial. Now, when you see at TCT thousands of cardiologists who are happy because of these events, some surgeons may think this is the end. And I think that you should not think this is the end, because this is, in my opinion, in my view, in my personal experience, this is part of surgery. First of all, we should understand that these procedures have been opening new perspectives. These are patients who have been treated, some of functional MR patients surgically even today if they need specific associate procedures. But in principle, endovascular procedures are perfect alternatives to surgery for functional MR, and only isolating the risk of the procedure to the mechanistic effect of reducing MR has been possible to produce some proof of concept, because co-op trial remains a proof of concept trial. It's very highly selected population, but it's a proof of concept that in very highly selected patients, there is a causality effect between mitral insufficiency and death in functional MR. I mean, this is something which we've been trying to develop for many years. Now, I think it's very important to share with you what has been my experience. When you operate open heart, and this is a sternotomy, but I can use whatever you want, you see very well the structures. You see exactly your target of your therapy. You can do whatever you want. You can even replace the valve, but you don't see the valve functioning. What you have with endovascular procedures, and this applies to annuloplasty, to chordal replacement, and so on, you see function as you work. So this, for me, is not different from surgery. This is more surgery, surgery 2.0. It's still surgery. We're still doing the same things. We only have different instruments, longer, more flexible, but still surgical instruments delivered through a catheter. So obviously this is expanding the portfolio and the options, as well as expanding the discussion. What is the best solution for the patient? Who knows? But we will never know if these two therapies, or these two, let's say, class of therapies, will remain confined into two silos. If we fight against endovascular procedures and cardiologists will fight against surgery. You know, in my personal practice, I integrate the two options and I try to deliver the procedure to the patient which is best for the patient, a tailored approach, which is not easy. I have to say, it's a very complex situation. And obviously by doing so, I've been also, and I'm at the moment very much criticized because I'm a little bit going beyond the limits. Surgery has been always on the limits. You know, check the limits. If you have a kid, that means a kid is always trying to check his own limits against you as a father. And what are these limits? You know, the limits are difficult to define because in all this area, what we have, guidelines which are all opinion-based. There is no evidence, no strong evidence. When we say we have long data, yeah, for sure. But according to guidelines, I see in the guidelines almost no indication beyond level C of recommendation, which means there is lack of strong evidence, at least the evidence which has an impact on guidelines. So what we remain handworkers, we remain experts, we remain craftsmen. We are building our own experience on our own practice. So I would like to share you my own experience, and the question is how do you incorporate this? It's not easy. How do you choose? I mean, there are obviously it's obvious that you try to choose the right decision based on the age of the patient, the comorbidities, the clinical status, the anatomy, the function, the wish of the patient, very important. And sometimes the decision is very simple. You get this young lady coming for a party in Zurich. She fainted and, she had a prolapse. We repaired this valve with a minimal invasive approach. You can do it with minimal invasive. You can do robotic, whatever. There is a lot of patients on the opposite side who really want to get something non-invasive. So 80-year-old, operable patient, because Euroscore 2%. Ideal anatomy for everything. Sternotomy, minimal invasive, robotic, chordal replacement, mitral clip. This patient is a patient that I have no problem to say, in my practice, I can get an excellent result with mitral clip, double orifice repair with no residual prolapse, no stenosis. Sorry, went a bit fast. I go back one slide if I can. It doesn't work. Yeah. One more, so it will work. It went a bit too fast. Anyhow, this video should show you there is no residual MR, there is no stenosis, there is no residual prolapse. So this is a durable result. Okay, what is durable in mitral repair? no residual prolapse, no residual MR. This will be durable. But has to be the target. I'm a surgeon. I don't accept a palliation. I will not accept palliation in these patients. As well as I do not accept, or I do not suggest such procedures to patients who can be operated and who have a bad anatomy for endovascular. This patient came to me explicitly asking for mitral clip because he was very busy. He didn't want to stop. He said, I went to Monte Carlo to Dreyfus. He wants to operate me, but I need a clip. Well, I convinced him to get a minimal invasive mitral because there was a very wide flail of A2, A3, and I repaired this with a minimal invasive mitral. And this was part of my practice. It's obviously having the expertise for both technologies. I can tell my patients what's good for them, including in some occasions to go for sternotomy. I mean, I have to say, if I have a MAC, I don't like to go minimal invasive. These patients require a lot of work, and these are standard cases for standard sternotomy. So again, it's about the full spectrum of therapies that you need to propose your patients. The landscape is very wide, and it goes from full sternotomy to truly transcatheter procedures. And the ideal setup is a setup where you can utilize these solutions in a complementary fashion, not as an antagonism. And I will go to the point of the last to convince you is this one. If you have a failure, you can treat the failure with something else. So I had failures after surgical repair, and I could repair with a clip, and I had failures after mitral clip that I repaired surgically. Some of them I did, some of them was patients that but I see really that no is really alternative. They are really complementary, and we need to use all the spectrum. Again, going back to the workshop. The workshop is where we have to go, and we have to understand. I will stop my presentation because I think it's enough. This is the point that we need to really bring forward. In this is an arena of experts, of surgeons who are expert in mitral interventions. We still discuss 1 year after the cohort trial who are the patients who benefit from this therapy. And we have been discussing about patient selection, pre-procedural treatment. We talk about heart failure before and after the procedure. Nobody is talking about procedural skills. What is the role of the operator? Mitral clip is a very complex procedure. It is a procedure that requires expertise, and this expertise in the hands of a surgeon could be the best solution for these patients because we know exactly what are the targets of therapy. So as a surgeon in my practice, I'm pretty sure that I have no doubt that these procedures may be improving the life of the patients only if they are in the hands of people with expertise. Just like for surgery, the expertise of the single surgeon plays a role, just like for surgery. Now it has been shown also for mitral clip. To obtain a good result, an acceptable result, everybody can achieve an acceptable result, a palliation, but to achieve good results, there is a learning curve which is not completed after 200 cases. So what is my final message? Whatever is the technology, whatever is the solution, integrate all the technical aspects in your practice, but don't forget the most important background for a successful procedure is deep knowledge about the anatomy, the function, and the objective of mitral valve repair. Thank you.
Excellent. Thank you very much, Francesco. As always, you've given us a lot of food for thought there, and we will get back to you with the discussion after the next last two presentations. The next one is Dr. Dente from San Raffaele, who will be speaking about technical step-by-step approach to the edge-to-edge mitral valve repair.
Thank you for the introduction, and thank you, Dr. Diosagno, for the kind invitation. I will start where Francesco, with the last Francesco concept. So it is important to have procedural skill, and it is really important to do the procedure in the right way. There is no doubt that mitral valve repair has been demonstrated by previous speakers. It's better than replacement. There is no doubt there is less morbidity, less mortality, improved long-term survival, and you can abolish mitral regurgitation, especially in degenerative settings. But the edge-to-edge jumped the border, and now we are able to perform it completely in a percutaneous way. But there are some surgical rules that has to be respected. First of all, the suture must incorporate the diseased segment completely, and you have to respect symmetry. And the suture length should be the different sizes for functional or degenerative MR, since they are different pathology and they have to be addressed differently with this type of intervention. This is original video, as has been already shown by Francesco, only for you to understand that the depth of bite and the length of suture should be differently. So you have to incorporate the all disease segment in the degenerative valve, and you have to be more delicate in functional mitral regurgitation valve. All these rules have to be kept into account when you start doing the procedure in a transcatheter way. It's really curious thing that also when Professor Alfieri and Maisano started to do edge-to-edge technique, they started with high-risk patient with complex anatomy and also in functional MR patient, and also used it to correct anterior prolapse. We used this type of technique also in functional patient, and as you can look at this data published, our group demonstrated that edge-to-edge was comparable, even superior in related recurrence of mitral regurgitation, also in more dilated ventricle in the setting of functional mitral regurgitation. In degenerative mitral regurgitation, our group also demonstrated 17 years follow-up with no or minimal residual or recurrent mitral regurgitation. So we are talking about the technologies, and then this is again a slide courtesy of Professor Maisano, where we can see that the surgical technique that has been conjugated in different ways, from open heart, full sternotomy, afterwards in video assisted, and nowadays full percutaneous. It has been a technique that has been criticized by some surgeons, but nowadays more than 100,000 of mitral cases have been done worldwide. As Professor Maisano said, it requires professional skills, and there are some rules also to respect during the procedure. That's why this is a more technical presentation. First of all, the transeptal puncture. The transeptal puncture is the position that gives you the possibility to arrive in the better way, in the more perpendicular way to the mitral valve. There are 3 echocardiographic views that tells you the best way to approach. So the short axis at the base show you the distance between the aorta, and the bicaval view show you the position between the superior and inferior vena cava. Once you have the good distance in these 2 echo view, you can go to the 4-chamber view to understand the height from the valve, which has to be differently from different operator, but at least 4 centimeters higher for degenerative and lower for functional. Once you have done a good transeptal puncture, so take your time to do the transeptal puncture, what you have to do is to look at the trajectory. And it is more important to work together with the expert in imaging to obtain the best intercommissural view. This has been done by the echocardiography expert Florian Deuschel of Hamburg. In order for you to understand, it's very simple, but you have to look at P1 and P3 and A2 in the same segment and the same view of the valve, and then the 2 papillary muscle together. You have to spend time to have the better view, otherwise you will never understand where you are. So you have to be guided, but also the person that guides you needs you to help to understand where you are. Can we go to the next slides, please? Again, once you have the best intercommissural view, you can go to the best free chamber view in order to understand if you are anterior or posterior, and anyhow, you arrive to the 3D view. The surgeon's perspective is that we know more than the cardiologist that there are chordae on the mitral valve, but unfortunately the spatial resolution of the echo is not able to make you see the chordae. But you have to remember that as you are in the central zone, there is a free chordal zone, and the more you go in the commissure, the less procedure is forgiving you. So you have to pay even more attention if you want to put a clip not in the real center. As I can show you here, the trajectory is really important, because if you are perpendicular to the valve, you can easily arrive in the place where you want. If for any case you are not perpendicular, but you go from lateral to medial or medial to lateral, you think that you are going to grasp one part of the leaflet, but you are grasping another part. So take your time to take the best trajectory using the knob of the clip. Once you have made your best trajectory, then you have to orientate the clip. Again, it's very simple. The trajectory of this clip is not that good, but we can see the orientation on the left side. So as soon as we are in the center, we have to put the clip in the anteroposterior orientation. We don't have to look to the aorta. Usually the aorta is between 11 o'clock to 12:30, but it's not important where the aorta is. We know that there is the anterior leaflet, the fibrous trigon, but let's look at the commissure, and let's look at the plane of coaptation. Then we have to go perpendicular to that. Once we have a good orientation, we can decide to close the clip to descend into the ventricle. This depends from the operator. You can do it for the second clip. I advise to do it so, but you can do also with the first clip. If you don't close the clip too well and you are into the commissure, what can happen as soon as you go up with the clip, maybe you impinge in some cord. So the closure of the clip could be a suggestion at the beginning of the case not to impinging of the cord. But again, it's a question of style and a question of training. After the descent, also when you go into the ventricle, it is important not to go too much depth into the ventricle unless you are suffering to grasp the leaflet, because the more you go deep into the ventricle, the more you risk to go to a chordae that are arriving to another part of the mitral. So when you are retrieving the clip, you think to grasp the desired part of the leaflet, but you are grasping a little bit more aside because you are following the chordae. But you realize this only when you release the clip. And again, this is an example of what never to do. But if you have trouble, don't go inside and outside with the clip open and closed, because you risk really not to have the best outcome afterwards. What we are able to do nowadays with the new clip, we are able to do more complex cases, especially in the generative setting, but there are different adjustments you have to do. For those of you that are not expert, the new clip, the XTR clip with longer arms, tends to be a little bit more parallel to the aorta, so you have to take into account this when you do your trajectory. Second, the new clip tends to be a more theory, but this means that you have to be more precise to be parallel to the valve, because with the older version of the clip, the clip was able to move a little bit and accommodate the movement of the valve. With the XTR clip and also NTR clip, this is less pronounced. So if you are not really precisely under the leaflet and not precisely with the parallel to them, you risk to have some problem. Again, this is a question of precision, but this is the same precision that we do in our operatory theater. Again, also the other than trajectory is the rotation of the clip. The XTR clip tends to rotate to move posterior and medially as soon as rotate it clockwise or counterclockwise. So you have to pay attention as soon as you rotate the clip inside of the ventricle, because you can move also the position, not only the rotation of the clip. And finally, when you close the clip, you have to pay a little bit more attention, because usually you have to dive inside of the ventricle as soon as you close the clip. This is evident in this example. If you pull the clip inside the ventricle and you close it, the arms of the clip tend to close at a plane that is higher than the annular plane. So you increase the stress on valve structures. As soon as you close the clip and you dive into the ventricle, what you can do is to release the stress on valve structure, since you are diving inside a little bit, and you don't have this stress on the structure, and you are closing perfectly at the plane of the mitral valve. So here an example of P3 lesion treated with one clip, with NTR clip, only one clip with no residual NR and clearly no residual gradient, because it was interconventional. We are able now also to treat systolic anterior motion, where other technology or like septal ablation or septal Moro technique are available. This is a patient that was treated successfully with one clip using isoprenaline. We abolished completely SEM and also obstruction. You can see here that it is a little bit of acceleration, but we were below free of gradient. As if you follow the rules, and if you are really operator that follow the rules and pay attention, you can treat also papillary rupture. There are registry now that tends to give evidence that this could be beneficial for some patient, but if you treat a patient with papillary mass rupture, is the worst environment where you can put a clip, because you have a small left atrium, and in any case you will have a low puncture, despite I know that Francesco has some idea of how to overcome this. You have a flail gap really that is really high, because you have the papillary muscle that is going to the roof of the atrium. You can impinge it into the clip, and you have also tachycardia, so you don't have the best environment. But this is an example of a patient that we treated in San Raffaele, and we have now more of series of 5 where we have good result in terms of reduction of mitral regurgitation. So it can be done. And again, this is a patient we have done last week. This is a patient with 2 impella, right left impella, 2 iris for surgery because it has a severe low platelet count, less than 8,000, and we treated with 2 clip, no gradient, no residual MR or minimal MR, and complete reversal of systolic flow in pulmonary vein. So we followed the rule, we had good result. But to follow the rule means to have the maximum result in terms of reduction of mitral regurgitation, because again, our group demonstrated that the less regurgitation you have after the procedure, the less event you have afterwards. But also you have to pay attention not to have mitral stenosis. So what do we call an optimal result? Which again is a difficult, it was a difficult patient. The video doesn't work, sorry again for this, but it was a patient with multiple jet where we implanted 3 clips. This happens 5 years ago, where we don't have TMVR at our center. That maybe was a patient that we would treat with TMVR, but that patient was treated with 3 clips, but with no residual MR and no gradient. This is a degenerative patient with 27 millimeters of flail width. We treat with 3 clips, with no residual MR, and also no gradient. But how can you guide this type of procedure? It's not only technical skills, but it also monitoring during the procedure of what you can do. Again, it was a patient with no MR after the procedure, but we are always looking at a continuous left atrial pressure monitoring. You can see here from the top before the clip implantation and the down video where we implanted to clip, the V wave also became a half, and also the mean left atrial pressure goes down. This has been demonstrated by a group of Maisano in Zurich, that once you have this correlates with event and survival and quality of life. Again, we have always to understand which is the best parameter, which is a multiparametric approach. So not only the gradient, but also the valve area when you start the procedure and after every clip implantation. Again, this paper demonstrated that if you start from T.6 in the functional and 4.8 in degenerative, you will never have a stenosis after 2 clip implantation. But to find the best balance between regurgitation and no stenosis, it's always difficult. But we can do it, because we know that in any case, there are some type of patient, and I'm introducing the next speaker. We know from the beginning that we have low chance to have a successful result because they have multiple jet, no ulnar dilatation, and excessive tethering, which say to us that the durability would not be so good. In this patient, maybe it would be better to treat with mitral valve replacement. We have this paper that surgically said that replacement is better than repair. But again, if you carefully look at this paper, there are a group of patients where after 2 years, if you have a good repair, you have a better reverse remodeling. So maybe you have to screen better this patient in order to know what is the best anatomical condition to implant a clip, a Pascal, a Cardioband, or TMVR. In conclusion, it's a matter of technique and skills. Transeptal puncture, trajectory orientation, and grasping are the skills. The evaluation as grasping and efficacy with gradient left atrial pressure and area are another technical rules that you have to follow in order to have the best result. But again, the best way to have the successful result is to pre-screen the patient as to have the best chance to have the better result. Unfortunately, nowadays we don't have enough anatomical data to understand which is the best anatomical treatment for each of these 3 group of devices, use them as a standalone procedure or in combination, especially annuloplasty with Cardioband and Mitral Clip. Thank you very much for your attention.
Okay, thank you very much, Paulo. So we will go on to our last speaker, who is Thomas Modine from Lille, who will be speaking about transcatheter mitral valve replacement ready for prime time. Thomas.
Thank you, Michael, for the introduction. So again, it's my time to thank Marco for the invitation. It's a very good initiative that, although it will not replace physical contact, which is very important for all of us, I think it increases the number of sharing and the access to this kind of communications and technology. So I think it's nice that this talk has been decided to be the last one, because it's gonna summarize a bit all that have been said. I mean, there's a variety of disease, there's a variety of anatomy, and I think the beauty of surgery is whatever the access that you have been choosing. The beauty of surgery was, and is still always, to be able to combine all the technological solutions and techniques that allows you to leave the patient to leave the operating room without any mitral regurg. And this is the limitation of the percutaneous therapy. So, sorry, just to take this in hand. Oops. So my next slide is the following one, if it works. It's not, yes, okay. So, I mean, I don't need to convince you, although few people may know this, that mitral disease prevalence is higher than the aortic stenosis. And also, because the prevalence is higher, it means also that the variety of the disease itself is much higher. So this is very important. I want to go quickly because I've been asked to stay on time. What few of us know and or accept or are really trying to address is the following, is that despite the diagnosis that could have been made very early, and this is something very strange, because if we are able, as Gino have been saying, to address, for example, a P2 prolapse very early before annulus dilatation, everybody will win and everybody will be happy. But the reality is that these patients are referred very, very late for us. And this is one of the challenges that we have to address and face much more than what's the option that you want to use. So this paper from Enrique Serrano team showed clearly that survival of asymptomatic patients undergoing medical management is even worse if the mitral regurg keep on increasing. So the problem is when to open the door and tell the patient that he has to go for surgery or any other treatment that you have been choosing. So we know that the gold standard is repair whenever it's possible, and we know that it's sometimes not possible, not feasible, much more than we think about it. In real life, I would say. So when you can repair, do it. If you cannot repair, replace. If you are doing a bad repair, try to replace. And if you are not convinced that you're going to do a good repair, replace. And replace, you have to replace if you fail also, or do it percutaneously, as Francesco has been saying. So I mean, at the end, you end up with more situations where you have to replace than repair. And what's strange is when you ask the industry about the number of valves they are selling in comparison with the annulus they are selling, it always ends up with 50-50 or more than 50-50, depending on the country where you are making the poll, I would say. So because replacement and cardiac surgery is based mainly on the fact that many of the surgeons, at least the reported series and the majority of them, to the submitral apparatus, at least the anterior one. And it has been shown clearly shown that if you don't preserve both mitral apparatus, the anterior and the posterior, it's unlikely to achieve something similar or equivalent to the quality of repair. And then there is something else that we have to keep in mind is the mechanism of the mitral regurgitation itself, because the anatomy is different, the mechanism of the mitral regurg is different. And as I said before, surgery can address all these mechanisms where mitral percutaneous solutions are only addressing a part of the problem, which could be either leaflet repair, cord repair, annulus repair, and rarely in combo cases, which are not very easy to use in all the centers and all the places, not only because of the cost. So this is, I like what Joseph Bavaria used to tell us many times. I mean, he was saying this also yesterday in this meeting, is that what's good in the registries is they tell us what we are really doing. It's not only what we should do, or what the science is telling us what's the right way to do it. If you look, for example, at this slide that also has been shown earlier by Professor Alfieri, I just want you to keep in mind the following, that in this realism cohort, it has been shown that 40 to 65% of the patients only could have leave the operation room, and with the follow-up with the mitral regurg, grade of 1+ and below. So that means more than 35% of the patients had and remained with the mitral regurg of 2+ and more, which is not really satisfactory, I would say, because if you want to compare it to standard, it has to reach the target, which is no mitral regurg at all. And then this very recent publication also that has been by Scott Lim at the virtual ACC, they compared the Everest 2 realism to Expand. So you know this Expand observational registry also in very selected patients and in highly expert centers also. Some follow-up, although it shows improvement in terms of efficacy of the treatment itself. But this does not necessarily reflect what's happening in real life, although it leaves some room to improvement and from a technical point of view. Real life is what has been reported in the DVT registry, and so although this one is the latest one, and the new one has been shown also and will be shared later on, the Mitral Clip DVT registry, it shows clearly that there is an unmet need, which is a great percentage of patients, although these are very selected patients which are not treated completely, and which, although they are having a very safe procedure with a very low mortality rate, they still have mitral regurg, and if they have a mitral regurg, we know that is going to lead either to mortality or some morbidities that need to be addressed. And on this basis, we can say that the advent of mitral replacement transcatheter solutions is real and is now in the field, and it has to be considered very, very carefully. There are many limitations. I don't know if we have time to address all this. Some of them have been mentioned before, which are the high rate of rejection, but also this height of rejection or non-eligibility of patients is due to the fact that we are still having the first generation of valves that have higher profile transapical, and by the different iterations that are coming, we know that we are getting away from transapical and moving to transeptal, and also we are having small or low profile valves with bigger diameters, which are addressing the two principal non-indications for transcatheter mitral valve replacement, which are the width or the diameter of the annulus itself, which means patients are later on. So from my point of view, I think the biggest advantage of transcatheter mitral valve replacement in comparison to repair is that, like in surgery, a replacement could fix the annulus, could preserve the cords, the anterior and the posterior mitral valves leaflet, and could adapt to any kind of anatomy. And it doesn't necessarily need high technical or expert in imaging, although we need fusion and the better understanding of the imaging. So quickly, I want to show you this Tendyne CE trial. So Tendyne has been granted now with the CE mark, with the first one ever with the transcatheter mitral valve replacement systems. So in JACC 2018, it has been reported and it has been presented on all the meetings so far. It shows clearly that the first 100 patients that we treated, the survival at 1 year was 72 years old. I mean, and all those of you who participated in the study knows that these patients, although selected also, they have been rejected to, for example, mitral clip. They are not eligible for surgery. So these patients were at very, very high risk. And despite that, the mortality rate at 1 year was really very acceptable. And these patients get a better quality of life. What's interesting to show, which is not met with the percutaneous repair, that these patients had almost eliminated, with this therapy, the existence of any mitral regurg. I cannot show it to you here, and at EPCR next week. In 2 weeks, it will be presented, the 2 years follow-up, and it shows the stability of this result over 2 years, which is very encouraging for this therapy itself, by replacing instead of repairing. The other challenger is the Intrepid valve from Medtronic. And although the number of patients that have been included in the pilot study in the beginning, there are ongoing randomized controlled trials with Tendyne, of course, but also with Intrepid so far. So it shows, if you look at these red characters I put, it shows you how the percentage of comorbidity these patients have. They are really patients with a very, very high risk. And despite this, treating these patients with the Intrepid system showed clearly to eliminate mitral regurg. A few of them had mild mitral regurg. The majority have had no mitral regurg at all. And what's interesting is that during follow-up, what we have been able to show is that this therapy is really very effective. At 1 month in the Apollo first enrolled patients, the mortality rate was only 2%. And this is, I mean, with this new beginning therapy is very, very favorable and could challenge all the percutaneous other repair systems that we have. Intrepid is working on a transseptal system that is supposed to be introduced at the end of this year or early next year with the early feasibility study. And this is very encouraging also in terms of increasing the safety of the device. I'm going to show you 2 more or 3 more devices which are available today. I'm going to focus only on transseptal. So the M3 from Edwards, it reminds you very clearly the S3 system, and it's covered entirely by the tissue, and it uses a docking system, and the catheter is more or less similar to the catheter we have with the S3. The High Life is going transseptal now, and they started the European study also, and this is also a very promising therapy and a solution that you have to watch carefully. And of course, the cardio valve is one of the most promising valves with this low profile and fully transseptal implantable system. We are waiting for longer follow-up, of course, and bigger reports. And of course, I mean, I was very proud to be able to do the first in man with the Cephea that has been now acquired by Abbott. So this is shortness of height and fully transseptal, probably atrial, surgically transatrial. The first case we did it in a patient who had a mitral regurg and severe MAC, as you can see it here. This is the first patient we did, and we are approaching the 3 years follow-up with an excellent result. So I think to shorten what I've been trying to tell you before, that repair is and will be always the best and the gold standard, but we should not make a confusion. We are all admitting and talking about surgical repair, which combines different procedures in one procedure. And the big question, we have been debating on this earlier, and we always associate a ring, whatever you are doing for repair. Would ring be considered in some cases as non-useful? And in that case, repair percutaneously could be a very good option. If not, consider replacement, especially transcatheterally and transseptally, because if you cannot have a good repair, you better offer your patient a very good replacement. Thank you very much.
Excellent. Thank you very much, Thomas. We're over time here, but I think we've got a few minutes left still for some discussion. There's several questions that have come in. One for Dr. Denti, but I'll put it also to Francesco as well. From Janesh from Great Britain. What are your treatment options for recurrent MR, significant recurrent MR after the Mitral Clip procedure? Paulo?
It's a very tough question. Unfortunately, since we are addressing a patient that especially in functional regurgitation settings that already are high-risk patient, if you have a recurrence of mitral regurgitation and there is no residual gradient, you can think of doing another mitral clip wherever you are already implanted. There is experience outside with Tendyne valve, so we are able to cut with the modified lampoon technique the leaflet, so you are able to put aside the clip in some way and then implant a Tendyne valve. But again, this is I think that nowadays it's not reproducible, it's very experienced hands in experienced center. Maybe Maisano can add for sure more, but what we are usually doing in this center is it's a redo mitral clip, but it is very difficult for many reasons, anatomical and also for budgeting purposes.
Francesco?
You know, I think first of all you need to understand why. The why. Is it a recurrent MR because of a lifted tear, because of a clip detachment? What is the underlying disease? Is it an operable patient or not, and so on. So everything is possible. In principle, there are many options. You can retry mitral clip, which will not probably, for instance, will not work in case there is a lifted rupture. You can't try again mitral clip. You can put a ring. You can replace the valve with tendine, or you can operate. I just want to give a message, because we are all surgeons here. We are very good surgeons if we attend these kind of meetings. These my suggestions were in front of a patient who have been treated with mitral clip, and you need to reoperate. Most of these patients are DMR patients, because usually you're not going to be easily operating an FMR patient who doesn't respond to mitral clip. But if you have a DMR patient coming back because the result is not enough, my experience is that in most of these cases, unless it has been done in the last 2-3 months, in most of these cases, they come to you after 6 months, 1 year after the procedure. I think in my practice, almost all these patients are still repairable. You just have not to try to take the clip out. Remember, it's an Alfieri with clip. You put a ring, you make little adjustments, and usually you get excellent results. So I have a number of patients where treating just by leaving the clips in place has been an excellent result in adding annuloplasty. So don't try all the time to take these clips out. This is a big mistake, because otherwise, after that, if the patient has been operated since more than 2-3 months, you have too much scar tissue. You will not have tissue available for repair.
But if you do want to take the clip out there, just so a little tip, there is a nice video attached to a JTCVS article on this. I forget which group did it. I think it was Columbia's group. And they got a nice video showing you kind of a step-by-step approach to opening up that clip. Even using the minimal invasive thoracoscopic or instruments, it's definitely doable.
Absolutely, Michael. I'm not saying you can't, technically, mechanically, you can reopen the clip. There is a way to do it. The problem is, and this is again, if you are talking if you're doing the right patients, if you talk to the patients and you tell them, we try mitral clip. If it doesn't work, we need to operate you very, very soon, because you don't want to wait for scar tissue to develop. Once the scar tissue is developed, then it's going to be very difficult to take the clip out. And I would suggest not to.
Okay, we have a question for Thomas. Talking about the anatomic exclusion criteria for transcatheter mitral valve, and is it as high as everybody always says it is? But I would add a second question to that. The lampoon procedure that Paulo alluded to, just maybe if you can just quickly describe to people what that is. Do you think that's going to open up a bigger patient population for transcatheter mitral valve replacement?
So this is an excellent question. I mean, it's like everything. I think it will add a difficulty to the difficulty. The lampoon limitation is the following: is that you have to be sure that you will be able to tear the mitral valve, the anterior mitral valve, in the middle, and just be sure that the valve is teared apart and get away from the LVOT. If you're not sure that you're in the middle, it can be a problem. It will not resolve it at all from this perspective. So honestly, it's very few cases has been done, and I'm not sure. I think the best it will be to avoid the lampoon is to have really a great effort from an engineering point of view that is made on having low profile valves, and it's coming. I mean, some of us are involved in some projects with a very, very low profile. Let me give you an example with my experience for example, with the Cephea. I mean, we have screened more than 30 patients, and none of them have been rejected because of the LVOT risk obstruction, because the valve was very short in the ventricle. They have been rejected for other reasons, especially the dimensions of the anatomy, because we had only one size at that time. So, but I'm not sure that a lampoon procedure, that's not always easy to achieve, to be honest with you, would be the solution. It would be sometimes helpful, but I'm not sure it's the solution.
But the flip side of having a lower projection in the left ventricular cavity and LVOT is that you're going to have a higher projection in the atrium. And doesn't that concern you that maybe you may have a higher thrombosis rate? Because that's also a big problem for these devices, right?
Yeah, definitely. I mean, if you look at what has happened to some devices that disappeared so far, and the latest one is the caisson from Livanova, which was a valve that was sitting higher in the left atrium, and to some extent also the cardiac U, which was also sitting highly in the left atrium. This is one of the major problems, and I'm not talking about the Alta valve also, which is completely sitting in the left atrium. So this is absolutely a good point. But for example, if you look at the design of the cardio valve, or again the Cephea, look at the Intrepid or Tendine, they are not. I mean, although the profile is higher, but the cardio valve is not sitting in the left atrium. I mean, Francesco can comment on this. The Saturn valve, in which Paolo is involved, also does not go in the left atrium, and it's very short in the left ventricle. So I mean, what you are saying here, Michael, is very important. But I think this is exactly what I said. We should not judge the TMVR today on the basis of the devices we have, because they are only the first generation. And what's going to show later on is going to be much better and adapted to the unmet needs.
Okay. Thomas seems to be
this valves to correct the mitral field.
Okay. Well, we've significantly overshot our time here, but I think there's still a lot of people watching. But we are going to wrap things up. I know there were several thousand people yesterday. I'm expecting probably several thousand again today. I just want to ask one last question. Francesco, do you think in the future that there's going to be a blurring of the lines between cardiologists and cardiac surgeons, and you think it's going to be one specialty, or is that just a pipe dream?
Well, I don't know. If I knew how to read the future, I would gamble. I don't know. It would be great. I can only tell you that I benefit a lot of this hybrid expertise, and I try to build some of my colleagues into this direction. On the other hand, we also have to be clearly say that there will be always a need for fully trained conventional surgeons who can tackle complex procedures. So what I think it could be, honestly, if one day, hopefully not, if one day I need a procedure on me, I would like to have somebody who has no bias. I would like to go to somebody who has no bias against one or the other procedure. So somebody who has interest of doing what is good for me.
Thomas, you want to just finish with the last comment?
You want to open
No, I mean, yeah. I want to heal you. No, I mean, we are lucky. I mean, here we are this generation of surgeons who love what we do, believe that we have a legacy. I mean, Professor Alfieri was here. We have a legacy about all what cardiac surgery brought here. Cardiac surgery was born thanks to the technology, and it will not vanish, because we will still need good surgeons to address the unmet needs and the failures of percutaneous therapy. So from this perspective, I think there is no other choice, because patients are more demanding than before. They go to internet, they check. And I think a communication based on the fact that in centers where we have a combination of excellencies is the best way to secure and offer the best therapy is the future. So from this perspective, I think that this is a big fight. This is a big fight, because we need our surgeons, not only you and me and our centers, to be convinced that there is a place and the future is also for percutaneous therapies. And also we need to convince the cardiologist and that they cannot make it alone if they want to put the patient in the middle. So, I mean, this is very rational. You get it?
Yeah, I think Michael is not anymore. We have some connection issues. I think it was a good summary of the discussion, and it all about passion and interest in bringing the field forward. I think is a very important message to the audience. We have been discussing now different techniques, different technologies. Remember, all this will be one day obsolete. All what we do today will not be used in 10 years from now. A lot of the things we're saying now are going to be disappearing. What remains is what the patients need, remains the disease. What will be our profession in 10 years from now? No one can tell. No one can tell how we will solve the issue of conflict between professionals. But overall, I am sure that there will be a solution. And we can decide to be part of the solution or not to be part of the solution. The best way to be part of the solution is to embrace whatever comes with an open mind, without any preconcept, and without being blocked by our own bias and limitations. So for this reason, I think that we should really thank Marco to organize this meeting, which is really bringing all these technologies together. Techniques and technologies are not professions. Profession is not defined by a technique. Otherwise, we are hand workers. So we are defined by our competence. So I really like to hear from Marco, maybe a closing remark, because I think we have been very much over time, and I thank you everybody for being with us. Marco, are you there?
Yes.
Yes.
I'm here. Thank you, Francesco. I think that no better statements could close this discussion from your side. I thought with this Congress, it was important to make a focus on minimal invasive and transcatheter techniques from the surgeon's point of view. And I think that together with a fabulous faculty, we have achieved that goal with this Congress. I like how you define the mitral clip procedure, a surgical procedure, you said. So I think as a surgeon, we have all the numbers to perform and cover all minimal invasive and transcatheter approach. This is, for me, definitely a must. So I think this session was extremely good as well, the mitral valve, and I hope you enjoyed as I did. Yesterday, we had more than 4,000 access to this meeting, and I think today we will have probably similar numbers. That's my hopes. And so I'd like to thank everyone, the viewers, the faculty, the sponsors, CTSNet, Noema, and also my team. We have worked so hard over the last 10 weeks to rethink and give life to this meeting in a different virtual nature. So I'm just closing with my warmest invite to come to Ancona next year, June 2021, for our second edition on minimal invasive and transcatheter cardiac surgery here from Ancona. It will be an in-person meeting. We will have a fabulous international faculty again with an exciting program. We will work on that. We will not just focus on valves, but also on CABG, atrial fibrillation, aneurysms, and heart failure from a minimal invasive and transcatheter point of view. So please come to Ancona, even though we're thinking about upgrading it to a combined live virtual. So hybrid, live and virtual. We'll see. We will let you know as soon as we make our decision. So thank you again for watching, for being with us. I had the feeling this was a really interactive meeting. The chat was hot. So thank you for being with us, and see you soon in Ancona. See you.